Hello, everyone. I'm Susan Hoffman, the director of UC Berkeley's Osher Lifelong Learning Institute. Welcome to our speaker series, where we bring leading voices from UC, the campus, and other experts to talk about current issues, scientific breakthroughs, and new thinking in a variety of fields. 100 courses a year we offer, and many, dozens of speaker events, and many field trips and other things to explore new relationships, creating a lifelong learning community. Today's talk, very important talk, is on mental health. And joining us is UCSF's clinical professor, Nicholas Rosenlicht. Dr. Rosenlicht's recent book is entitled My Brother's Keeper: The Untold Stories Behind the Business of Mental Health and How to Stop the Abandonment of the Mentally Ill. Today's presentation is recorded and will be sent to all registrants once it's been captioned. Please add your comments and questions in the chat, and Nick will respond after his presentation. Thank you for joining us. And Nick, the floor is all yours.
Thanks a lot, Susan, and welcome everybody on this nice, bright Friday morning. I'm going to back up now a little bit and talk just a bit about why I wrote this book. I've been in psychiatry and addiction medicine for 40 years, and I've been in academic institutions primarily, although I've run community mental health centers. I've taught, I've done research, and as I'm sort of winding down my career, I was just struck at how I think we're doing a worse job than we did 40 years ago. I entered this field figuring, hey, we had new medications, new psychotherapies, new imaging techniques. Psychiatry was becoming more scientific. We were going to make great breakthroughs in the next few decades, and I wanted to be part of it. Well, it hasn't really worked out. And I hear people say, like our health system is broken and you can't help mental illness, they're not treatable. All of this is completely false. By the fact that you're attending this lecture today, I'm assuming that you have some sophistication and probably personal experience with the mental health field. It may be through a relative or a friend or a relative of a friend. And I can also make that guess, not only that you're attending this lecture, but the fact that everybody is affected by mental illness. These are very common disorders and they're throughout our society. Everybody has a weird uncle or brother or a friend's kid who's been in distress and life has been really affected by mental illness or substance use. Yet we act like it doesn't affect us. I mean, I go to parties and people tease me about being a psychiatrist and what a weird, worthless field, and the public portrayal of psychiatrists as malignant or uh, useless. But after the party, people catch me by the coat room or they call me the next morning. They want their personal guidance on about handle a problem in their life because these problems are so, so common. So I'm going to try to leave time for discussion at the end to answer questions. What I'm going to do is there's probably not that much I'm going to tell you that you don't know, but what I want to do is tie together these seemingly disparate threads to point out that we exactly on purpose built this system and it isn't working and we need to fundamentally change it. I mean, the kind of fixes we've been trying for our healthcare and particularly our mental health care, it's like whack-a-mole. Unless we fundamentally change the way we approach things, I don't think we're going to get anywhere. So anyway, I'm going to start with our general healthcare system, which is a bloated mess. This is life expectancy of people in the United States versus other developed countries. We have a shorter life expectancy than any other developed nation by 4 to 5 years. The tragedy is that kids born today have a shorter lifespan expectancy than their parents. This is outrageous. The other thing is that the reason for this decrement is largely mental health and addiction illnesses that are taking out our young. Yet, this is not because we lack expertise in the field. Uh, this is not that we don't have medical and pharmaceutical advancements that other countries have secret access to. This is not that we don't have well-educated and trained clinicians. This is not that we don't have the financial resources, although people complain about it. We have more than the financial resources. This is comparing the U.S. healthcare expenditure as percentage of GDP as other health wealthy nations. We spend about twice as much on healthcare as other developed nations, yet have far worse outcomes. Why? It's really quite simple. In our system, profit is prioritized over outcomes. Um, for the past 8 years in a row, the Commonwealth Fund has rated the United States healthcare system as dead last among 11 developed nations on measures of quality, access, equity, efficiency, and healthy lives. Um, Bloomberg, the conservative news organization, rated 56 nations on the efficiency of their healthcare system. We came out 54th. We tied with Azerbaijan and we beat out Bulgaria, widely viewed as the most corrupt nation in the European Union. Go USA. So what are the results that this shows? Well, 41% of this country have healthcare debt. 2 out of 3 people report having to cut back on food, clothing, and other basics to manage this debt. Medical debt in collection exceeds all other forms of debt for Americans, and 2/3 of Americans who file for bankruptcy cite medical costs as a prime reason. Half of Americans have had to delay or do without health care over cost in the past year. And most of these people have health insurance. We're not talking about just the poorest among us. Is it broken, our system? Well, that all depends on who you ask and your criteria. Some ways, we're doing great. The revenue of healthcare corporations has soared. The example, and that's made famous by Luigi Mangione, United Health, which is one of our biggest healthcare corporations, its revenue last year was 200, I'm sorry, $394 billion dollars. 23 billion in profit. Now, these are dollars we pay for healthcare, but are going to somebody's profit and don't even provide better health. Why do we have this big suck on our healthcare dollars? Over the past 20 years, healthcare companies' payouts to shareholders have tripled. In 2022, it was $170 billion to shareholders. Now, these aren't even people who work for healthcare companies. We're just paying investors money that's being diverted from making us healthy into making other people rich. How did we come up with a system like this? The healthcare industry is the largest lobbying sector in our country and the largest contributor uh, campaigns for federal employees. Oh, those are dollars that are supposed to go to our health. They're going to pay politicians uh, to to basically vote against our health interests. How did we come up with a system like this? There's this gigantic financial juggernaut that we've built. For every one physician in this country, there are 16 other healthcare workers. Sure, 5 of them are nurses, physical therapists, social workers, therapists, uh, dentists. But 10, 5/8 of these 16 do not deliver healthcare. They manage the financial aspect of our system. These are people who manage, but mainly block our access to these dollars so that they can make profit rather than make us healthy. An example of this is that there's an estimate that Americans spend 500 million hours a year on the phone with their insurers. That's more than what, an hour and a half for every man, woman, and child in this and uh, they in this country. Why? And this is all part of the system that's making it difficult to get the care we need. And about being broken, mental health care is merely the worst aspect of our healthcare system. Mental health has higher pays, higher deductibles, lower plan maximums, limited treatment coverage for kind of therapy you'd get or medications, or the duration of care, stricter prior authorizations, and authorizations to continue care. You get told, oh, the treatment hasn't worked, so we're cutting it off, or oh, the treatment's working, you shouldn't need it anymore. We don't do this for other forms of care. Healthcare, and primarily mental health care, is now the largest and the most profitable sector for the financial industry, especially private equity and venture capital investment. How did this happen? As a matter of fact, all these restrictions I'm talking about, they were really pioneered in the mental health sector, and now they've spread to the rest of healthcare. Have you tried getting an appointment with a specialist these days? Months wait. The same sort of restrictions that apply to mental health care have worked so well that our system is now employing them throughout healthcare. Insurers pay mental health clinicians less or not at all. So even when the coverage is offered, it's like, for example, 24% lower than to primary care, even though for the same procedures. The average payment this is in 2016 for a visit to a psychiatrist was $159. It was more than twice that to a cardiologist or an orthopedist. These are other medical specialists, even though those visits are far briefer. And there's also other charges for these procedures and tests and these other things. Um, uh, it's estimated that health insurers allocate about 4.4% of the healthcare dollars to mental illness and addiction. This is a small fraction for very, very common and devastating illnesses. And this is for people who are using insurance. Visits to psychiatrists are paid completely out of pocket 15 times more frequently than to primary care. These are people who can afford it. For most, they just go without care. Half of psychiatrists do not take not one single health insurers. This other half may take one or two, but not many. If you look on your insurer's site, you'll see these lists of mental health practitioners, psychiatrists, and therapists. They're called ghost networks because studies have tried to make appointments with these clinicians, and most of them, often the numbers are wrong, the practices have closed, they no longer take that insurance, or they're filled already with people on the insurance plan because they'd really rather take somebody who actually will pay them full price. There's other ways that mental health care is squeezed out. I mean, there's a lack of clinicians. I mean, the payment's been so poor. In 80% of non-metropolitan areas in the United States, 80% of counties do not have a single psychiatrist. 60% don't have a single psychologist either. Lower qualifications are now being required. For any other organ, your teeth or your feet or your liver or your ear, you're going to see somebody with a doctorate. In mental health care, the insurers will usually send you to somebody with a master's degree. Uh, you'll often have that happen for other organs, but the care is directed and recommended by someone with a doctorate degree. Now, I don't know if this is correct or not, and a lot of this has to do with the AMA's very protective financial stance, part of our business model. But why is it different for our brain, the most complex organ we have? We're going to go see somebody with a 2-year degree instead of an 8-year degree. Why is there this distinction? Most of the therapists I know, master's level therapists, are very dedicated superb therapists. But why do we have this double standard by organ? There's supposed to be parity, which is say equal benefits for mental health. But a recent example is United Health had to pay a $15 million fine for violating federal and state laws and putting tighter restrictions on mental health care. Um, well, that sounds good, except when you realize if you have a $400 billion revenue, that's like giving, say, a person who makes $100,000 a $4 fine. I mean, these are not even slaps on the wrist or rounding errors. Well, what are the results of this limited mental health care availability? During the pandemic years, 2020 to 2023, the 4 years, we lost over 1.1 million people to COVID. It was a tragedy. And it overturned our society with lockdowns and mask mandates and bailouts to businesses who lost business. I heard somewhere that I think the cost of the pandemic shutdowns was greater than that of the Depression. Meanwhile, during these 4 years, 1.3 million people were lost to suicide, overdose, and alcohol illness, more than to COVID, which is basically ignored, as I said. Suicide is now the second most common cause of death in 10 to 24-year-olds in this country, behind only accidents. There was a 2023 Kaiser Family Foundation poll that found that two-thirds of American adults, either themselves or a family member, experienced addiction to alcohol or drugs, homelessness due to addiction, or an overdose resulting in an emergency room visit, hospitalization, or death. These disorders are not rare and they're not harmless. In 2018, which this statistics are from, less than half of adults who had a mental health diagnosis received any treatment for their care. 1 in 5 people who have an opioid use disorder obtain any treatment at all. This is while overdose deaths tripled from 2010 to 2020. I mean, these are disastrous things happening that we're just ignoring. And I mean, it affects all of us. For all our worry about violent crime in this country, we're twice as likely to die at our own hands as those of another, and 5 times more likely to die by overdose. Yet, we worry about crime, but mental health, we don't do anything about it. How and why did we let this happen? Um, you know, Societies throughout history have had a long and entrenched social discomfort and stigmatization of mental illness. I mean, I like the way the French philosopher Michel Foucault put it, that we just can't wrap our head around. We don't like, and it disturbs us, those who cannot get a grip on their inner lives. I mean, our mind and our inner workings are what makes us, and it's so disturbing to talk to somebody who clearly doesn't have control over their inner minds. And people ranting on the street are extremely disturbing. I mean, if somebody has a heart attack or falls, passes out, we rush to help them. When somebody's ranting on the street, man, we go the other direction. It's not pretty. How do we view this mental illnesses? As an example, I think this defines it well. 1.3% of philanthropic giving in this country goes towards mental health. And this is made easier by putting things in economic terms. We can avoid viewing mental illness like other chronic illnesses. I mean, hey, it's like, your iPhone, you buy it from the store, but it kind of shields you from the fact that a 15-year-old is working 16-hour days to make it for you. The company acts as a shield. Same thing goes on, I think, with mental illness. I mean, we don't want for people to die in the streets, but after all, I mean, if you don't have health insurance or you can't afford to pay for care, I mean, hey, that's the system. I mean, it's not my fault if you can't play by the rules. I mean, excluding them is only fair. We all play by the rules. It provides this bulwark against worrying about the people who are dying around us. the brief chronology of mental health care in this country. Uh, I mean, most of you know some of this history, but in the mid 1800s, we were outraged by the treatment of the mentally ill in this country, who were largely a family responsibility. They were locked in basements and pigsties, and they weren't actually, people didn't want them out on the streets because they thought that they might infect those around them with bad humors and mental illness. But the asylum movement decided that these people were worthy of care and they needed kind, compassionate care. However, they were sequestered away from society, again, kind of othered in these asylums. But these asylums were grounded in an integration of moral therapy and medical care, which followed principles of kindness, mildness, reason, and humanity. And they initially apparently worked very well. They had um, supposed discharge rates of 80 to 100%. It's interesting that Dorothea Dix was one of the major supporters of these institutions. She chose to spend, she didn't herself have a mental illness, but she chose to spend the remaining final years of her life in one of her institutions. And but what happened is by the middle of last century, these places became crowded hellholes. Um, they were the care degraded, they're uh, just horribly overcrowded. A fact that I think escapes most of us is that by the middle of last century, one out of every two hospitalized patients in this country was psychiatric. Every other hospital bed in this country had somebody with mental illness in them. And they were horribly overcrowded. But people were realizing how awful these institutions were. So there was a movement, uh, and there was an anti-psychiatry movement. There was a right-wing movement where people like the John Birch Society didn't like the government having control over people. There was a left wing like the ACLU who didn't like government intrusion in lives. There was the whole in the 60s, the establishment, anti-Big Brother movement. There was a great movement to clear out these institutions. There were some exposés like in Life magazine. There was movies like The Snake Pit, books like The Shame of the States by Albert Deutsch, who revealed these places to be just terrible. Deutsch likened what he saw to concentration camps, pictures from what the Nazis did. There was also hope. Psychoanalysis was offering what they thought were cures or even prevention of mental illness with proper upbringing. There was the new medications, which promised great relief to symptoms. I'm sorry. Anyway, uh, an interesting fact that Deutsch uncovered is that the amount of money we spent on these institutions by the 50s was $1.25 for every patient. That's about $16 in today's dollars. We were supposed to feed, house, clothe, provide care and therapy for these people on $16 a day. We spend 10 times that now on throwing these people into prisons. John Kennedy, President Kennedy, I don't know, many of you may know about his sister, Rosemary. She was apparently an emotionally erratic young woman, and Joseph Kennedy, John's father, sequestered her away in an asylum, worrying that it would torpedo the political aspirations of John, Teddy, and Robert Kennedy. While there, they finally ended up lobotomizing her, and it was botched. She ended up a horrible invalid for the rest of her life, and this affected Kennedy. His last law he signed on Halloween Day, 1963, 3 weeks before his assassination, was a national plan for mental health. And he wanted to form a network of community mental health centers, treatment in the community, outpatient, for all these people who were stuck in these horrible institutions. And it was a grand idea. Unfortunately, after his death, it was never adequately funded. The places that were built were basically manned by uh, less trained clinicians who really couldn't handle major mental illness. There's minimal staffing, and pretty soon the funding really just went away. It was revived briefly by Jimmy Carter and Rosalind Carter, but that too died under the Reagan administration. Uh, but what happened is, I mean, psychiatrists, they became psychoanalysts and took off for the big cities. What happened is care went from these state-funded asylums to the private offices. But one problem happened. The poor and the uninsured were left out. These are the results. The dark blue line, you can see the number of hospitalized mentally ill, mainly in the asylums, went from 500,000 to now maybe 1/10 that. So where do these people go? Um, well, they ended up, you'll see these two other lines. We now probably have close to 400,000 homeless, I'm sorry, incarcerated mentally ill. They have now gone to jails and prisons. The three largest psychiatric facilities in this country are the Rikers Island Jail in New York, Cook County Jail in Chicago, and LA County Jail. This is where the largest number of mentally ill are treated. Someone with mental illness today is 10 times more likely to be in jail or prison as in a hospital. Or they ended up homeless. And it's estimated we probably have around 300,000 homeless mentally ill now in this country. So the humanitarian promise of deinstitutionalization became a nightmare of financial and societal abandonment. We now have 1/25th the number of psychiatric hospital beds as we did 50 years ago. Interestingly, in the decades following deinstitutionalization, in the remaining institutes, the number of the population of state hospitals declined, of course, but the number of admissions doubled. What we got was called the revolving door. People would be admitted briefly, discharged rapidly, admitted again, end up on the streets, and discharged, and each time going down a bit in their level of functioning until they usually died. A 2023 study in San Francisco found that the homeless were 16 times more likely to die a sudden death than others in the population. People with a mental illness are 16 times more likely to be killed in a police encounter, usually due to their erratic behavior. And you also have to remember, if you have a heart attack or you fall down on the street, medical responders are sent to take care of you, EMS, EMT, and paramedics. If you're having a mental health crisis, police are sent out to get you most places. Serious mental illness is associated with a 10 to 20 year reduction in life expectancy. So, how has this product improved since being made into a business? Our most effective psychiatric drugs that we have today are all more than a generation old. Far and away the best treatment for medication treatment of bipolar disorder is lithium, which was first used in 1948. Our most effective antipsychotic is clozapine, which was made in 1956 and sold commercially in 1972. The most effective anti-anxiety medication is the benzodiazepines, especially for panic disorder. There's a lot of talk about their dangers, which are real. People can become dependent and addicted, and they're very hard to come off of. But I was just in Mexico. You can get them over the counter there, and you don't hear about great problems with benzodiazepines there. The problem is how we use them. We throw them out like candy and without proper monitoring because we don't have the money to pay for the monitoring and assessment of care. Other ones like imipramine, one of the tricyclics, and some of the older like MAO inhibitors are just as successful at treating depression as our newer agents, admittedly with more side effects, but we just have not gone ahead in these 50 years. It's a sort of funny Goldman Sachs financial advisement that was sent out to the pharmaceutical industry saying they were giving caution about hepatitis C, which is now curable. And they said, you really don't want to do that because if you develop cures for illness, this would hurt long-term profits. And that's what happens now. We do these Me Too drugs, which you know will work because they're based on and modeled after existing drugs, but they no, work no better. But being on patent, you can charge a lot of money for them. How does the economic model change the nature of care? It turns people into a client or a consumer, and you avoid the medical model, you follow a financial model. But this is antithetical to the history of how medicine has been practiced. I mean, a lot of people, and people I know, hate the quote medical model. This is not the medical model we have in this country. What we have is the financial medical model. In medical care, there's an obligation to ethical conduct, the interests of the patient coming first, to do no harm, confidentiality, responsibility to the patient coming first and to society. These have been just swept away now that we're run under a financial model. Healthcare information is bought and sold and stolen because it's valuable information. The interests of the patients do not come first, and there's been a lot of unethical behavior. And treatment of the mind is relegated to second-class status. Now, by framing mental health treatment as different and distinct from medical treatment was a crucial rationale to allow insurance companies to disqualify it from insurance reimbursement. Insurers love to call people they serve clients, but it's only in mental health care that that term has been embraced by the clinicians. And I think that's because the term psychiatric patient is so threatening and so stigmatized. I mean, you're going to have people, how many people are going to sign up to come to care for you if you're calling them a mentally ill patient? It's that threatening. But if you think about it, if you look at like the LGBT community, I mean, there's been massive gains in acceptance by embracing formerly derogatory terms like gay or queer. By using the term client, you're actually entrenching and solidifying and validating the stigma around being a mental health patient. There are consequences of this. A long 25-year Kaiser study found that 60 to 90% of primary care visits are precipitated by psychosocial problems. Yeah, these people have physical illnesses, but that's not what brought them in. And it's unquestionable that this occurred because these people couldn't actually get mental health care. You have to remember when somebody's a client, they're paying for a service or a product to help them with problems in the external world. It's a passive relationship, and it signifies the monetization of a relationship. It's actually kind of a derogatory term in business. When businesses refer to a client, it's usually a problematic person, a Karen, that I please yeah, go talk, take care of that client. It's someone who has a complaint. It's a way of distancing yourself, being less empathic to that. Veterinarians get this. Veterinarians have both patients and clients. Patients are the ones they treat and make better. Clients are the ones on two legs who pay for the visit. Care would save money. Those with mental illness and drug problems are high utilizers of medical care. It's been shown time and time again that treating mental illness actually saves us overall healthcare dollars. There was a study just came out a few weeks ago, this year, that a company that enhanced mental health benefits found that every $100 spent on mental health care saved $190 in overall healthcare costs. Untreated mental illness has been estimated to be costing us $300 billion a year. And there's all sorts of hidden costs in this, like 1/5 of police time is spent in major cities taking care of the mentally ill rather than dealing with real criminals. We spend 80 billion a year on incarceration of people who are mentally ill, who would be better served getting care, probably in the community, not even in a hospital. A funny statistic I found is that in 2021, the LA Fire Department had to respond to 9,000 homeless related fires. Well, these people have to cook. And if you have them out on the streets, how are they going to do it? And it gets away sometimes. How about restrooms? Have you gone on Market Street? I used to commute into UCSF on BART every day. I mean, one day there was a guy just screaming bloody murder, and I wasn't sure what it was, but seeing what it was a young guy who was defecating on the steps into the BART station. He was trying to keep people away. I mean, is this serving society to have people living out there not even providing them with restrooms? I mean, this is just gross. We can't really fix our system until we understand our motivations. And there, I think, is the key. We need to understand our motivations. Otherwise, dealing with all these corporations and stuff and people who have an interest in making money, it's just a game of whack-a-mole. This is from Joel Bakan's book about the corporation. This is a wonderful quote, I think. The people who run corporations are, for the most part, good people, moral people, but the money they manage is not theirs. They can no sooner use it to heal the sick, save the environment, or feed the poor than they can to buy themselves villas in Tuscany. And this isn't, our system makes us all into evil people. We don't have to be working for a healthcare company, even though that's 15% of our population. Here's an example. In 2022, the shareholders, these are just stockholders in Pfizer, Moderna, and J&J, the three vaccine manufacturers, voted to keep their technology secret and not share it so that cheaper vaccines could be made to be used in other countries or poor in this country. They voted to hang on to their dollars rather than share technology that would save hundreds of thousands or perhaps millions of lives. But hey, it's my money, my precious. So what can we do? I think we need to stop seeing healthcare as a business opportunity. We save money by providing healthcare, preventive healthcare, and it's also a community benefit. When people in my community are healthier, I benefit. I think people are coming around to this. I mean, it's become more public. 9 out of 10 adults today say that there's a mental health crisis in the US. Well, what are people willing to do? They also feel that the mental health is the single greatest health concern for Americans. But again, what are we going to do about it? We have an answer, and it's an answer that every other developed country on this planet has done. We've developed comprehensive healthcare where everybody gets healthcare. It's called single payer, and it's been derided in this country, but polls show in other countries they are universally much happier than those in this country. It's time for us to do what the rest of the world has done. And it's time to establish equal rights for all organs. Stop othering those with mental illness. Stop calling them clients. Stop making them a business deal. There's a great quote from the humorist Oscar Levant. He said, "I went to my doctor. He told me my illness is all in my head." What a terrible place for it to be. And we need to stop the segregation of care. We have Jim Crow for mental health, separate but supposedly equal. We need to just incorporate all organs into healthcare and stop where you have to go to a different clinic for mental health. Uh, uh, I mean, it's funny. Do you have in clients and out clients? I don't think so. Steps we can take now. We need to let our legislators know, yes, they're getting rich off of us, but we don't want to elect people who are making money on keeping us sick. We need to let them know we want better. We need to enforce corporate practice of medicine laws. It is illegal in every state for medicines for corporations to practice medicine, and they hide behind fig leaves like they'll put up a medical director. There was one guy who was like medical director for 500 clinics and hospitals. Healthcare is so expensive that you can't get it now unless you have insurance, and that is doled out by corporations. They're making the decisions. We also have models that work. In 1960s, Franco Basaglia, an Italian psychiatrist, came and saw Kennedy's community mental health centers and took it back to Italy to Trieste. Trieste. It's now the WHO model for mental health care. We have community clinics, largely outpatient care, peer counselors, support, housing, vocational support, because being part of the community and feeling like you're giving to it is an important part of making us all feel better. There are models like this in this country. Cahoots, the crisis assistance helping out on the streets that started in Eugene, Oregon, has been saving them millions of dollars in uh, criminal justice, and police activity, and keeping people out of the hospital. And it's being incorporated in some other cities. We can do that elsewhere. Join organizations that are advocating for the mentally ill and for universal care. NAMI, the National Alliance for Mental Illness. There's National Single Payer. There's Physicians for National Health Plan. Out of Washington, there's No Health Without Mental Health. Support these organizations. We need a political movement to really turn this around. Our lives depend on it. Anyway, this was a really quick, rough run through of what's in my book, and I'm happy to take questions. But there's just so much I glossed over that I think you'd find uh, interesting, or I hope you would in the book. Anyway, thanks so much for your attention.
And, and Nick, thank you. I think that we so much appreciate how comprehensive your presentation is. I know you were feeling like you were sort of running through a lot, and you were. And there are a number of questions. I think it does look like we've got some time
Okay.
to answer the questions and to go into areas where you might like to take us. I mean, obviously, the first question that came up was from Karen, who sort of questioning who the shareholders were in this corporate healthcare model. And she was asking, aren't many of the shareholders people who work within the industry? Do you know who the shareholders are of things like Pfizer, Moderna,
I,
J&J?
I don't offhand, but actually, it's you and I. These
Uh-huh.
are, we have our 401ks or other things in these funds which are invested in these healthcare companies. Why? Because they're so successful. I like to quip that, the money we invest in funds, in 401ks or other things that invest in these companies that say we're saving money to send our kids to college. This money is being made on companies who are closing the hospital that would save their life when they inadvertently overdose at a dorm party. Yeah, we're getting money, but we're putting our lives at danger investing in these companies. And it's you and me and where we're investing our money.
Mm.
Yeah, a lot of them may be healthcare workers, but it's not that. It's all of us.
All of us. Okay, that's great. So, that's important to know. I mean, that we do have some control over. The suggestion that Rishi had was that she was recommending a film. I don't know, Nick, if you've seen it, called Bedlam Film. I Go ahead.
I haven't seen it, but I think there's a book associated with it, and it's very, very good. I have it right here. But there are a number of good books. I mean, movies out too. Uh, um, and I would encourage to see them too. It's really, I mean, they make real the crisis out there. I'm sorry, but I haven't seen Bedlam actually.
Okay, well, good. It's good for us to know. Put
Yes,
that on the
thank you.
to be watched list. I'm curious about the CMHC model that was in the legislation that JFK passed before his assassination. You mentioned that Trieste picked it up as a model. Can you tell us anything else more about how it works at a community-based level? Some
Well,
factors?
they have community centers. They operate 24 hours a day. They have often peer counselors, so someone in crisis can deal with somebody who knows what they're going through. They are kept in the community. They're not sent off to some asylum elsewhere. There may be some beds where they can stay overnight if they do. They are incorporated in the community, so they feel a sense of responsibility, and there's reciprocal responsibility. You know, an interesting thing that some poorer countries than us, like India, for example, do far better in managing major and mental illness, often without medication, because the people are kept in the community and are felt to be part of the community. You know, we think of the mentally ill, these weird people and all this, and there's even some of the books sort of make us think that, like, Ellen Saks's The Center Will Not Hold, and
Mhm.
Kay Redfield Jamison's Unquiet Mind, and the recent The Best Minds, which look at, I mean, they're very moving, but these are not typical people with mental illness. People with mental illness are other ways regular people. They are our relatives. They want to be part of society and belong, but they often are too confused to do that. And that's what Trieste tries to do. It tries to keep people in the community, keep them connected, keep us connected to them so we'll help them instead of othering them, making them a business problem, a financial liability. It's actually financially better if we can keep people in society, keep them productive. And that's what Trieste model does.
And in that way, can you also talk about the role of the family and how can the family be best integrated into the care?
Well, that's a hard one. And I mean, the asylums were developed as a relief to these poor families who had responsibility. But if we make it more of a community responsibility, and we don't shame families for having somebody with mental illness, I mean, how many families have this, but we all act like it's some aberration and an embarrassment because, you have diabetes. I had a patient recently, a very sophisticated woman who has two grown kids now. One has diabetes since a child, and one recently developed a serious depression. And she was freaking out about, how do I manage this son with depression? Then she realized, I've been managing this son with serious diabetes for 20 years and it didn't freak me out because there was a support system, a view that this is what we have to deal with. I think that's what families would like, not to be shamed and to know that they can turn to the neighbors for help. They won't be ridiculed or avoided if we can understand that these diseases are common and with treatment can be managed.
Thank you for that. I think that that so much, you know, refers back to your book of My Brother's Keeper and sort of the responsibility we have to each other and to our community to help people, be as well as they can be. One question came up from Hank. Why does the Bay Area seem to be a hub for the mentally ill? Is that
Well,
true? Or is that,
well, there are a lot of metropolitan areas. I mean, go to LA, it's probably even worse. I was just up in Seattle, it's the same thing in Portland. I mean, I think it's major cities who often there's the hustle and bustle and they can kind of stay hidden. I mean, the police aren't going to rouse them out. I think it's a more tolerant populace. I mean, when you sleep on the streets, I mean, you have a great risk of having all your belongings stolen, getting set on fire, kicked. Uh, and I think some cities like San Francisco are more tolerant, and so that does make it a place for people to go. And we do provide more civic services. But the majority of people on the street in San Francisco actually are from around here. They live here. And I mean, I don't think that it's that we're a great hub for people to want to come to. It's just more visible here because we're a little more tolerant.
Mhm.
And I think it's also historical. I mean, the 60s and the summer of love. I mean, there's sort of a sense that we should tolerate people even if they're behaving badly. But we're not actually doing things to help them by letting them, stepping over them on the streets or giving them $1. I mean, that almost sort of telegraphs how the difference is that I have money, you don't, and I can throw you a buck, but I'm not going to actually let you live near me or hire you.
And this is one of my own questions. As you were talking, I was thinking about, as you talked about, if there were someone, who stumbled on the sidewalk or appeared to be having a heart attack or a stroke, we would go to their aid. But with someone who's screaming, we turn the other way or walk the other way. I mean, obviously, as a societal issue, there are so many ways for us to be involved, and we're not, and we need to be. But in the instance of faced with an individual who may seem terrifying, what is the best response?
Well, I think personally, I mean, you can, I mean, cautiously feel them out if they need some help, but I don't, you know, the the emotionally disturbed can be erratic. They can be confused. They can lash out at the wrong people. But that's when we do reach out for, I mean, like in my city, we do have mental health outreach, and more cities need that. But you do, I mean, personally, you don't want to get involved. I mean, there was an incident in the Daniel Penny strangling Jordan Neely to death in the in New York. And I mean, so many people supported Neely because we've had the experience of being scared or harassed by someone with mental illness. Um, I mean, I think we do at a societal level have to expect that our society will manage these people better. It is ruining our world to have to be worried going out that we're going to run into somebody who's going to rant against us. But individually, trying to calm somebody down is not what you want to do. It isn't.
Okay.
You need to call the authorities, and the authorities need to step up and be more available. I think we would feel better about these people if we knew they were under care and were not going to go off and
Mhm.
attack people.
Great. Thank you for that response. And I know that it is much of the work of the EMTs and the fire department, responding, to these kinds of issues, on the streets. I live in San Francisco, and, I know, having reported a couple of incidents when I've been out walking. Do You mentioned the Trieste model that was sort of fashioned off of the JFK legislation. Are there other national examples or other international examples that you might point to?
Well, there are other countries. I forget one of the Scandinavian countries has a very similar model where it's basically care and acceptance first. And our country, we really treat mental illness as a crime. I can't, when a patients want hospitalization, I can't get them in because their insurers will say, oh, they're not suicidal and they're not homicidal, and they have a family who can care for them. We won't pay for it. What used to be the criteria for involuntary hospitalization has become the criteria for any hospitalization. If somebody needs hospitalization or really desperately wants it, we don't give it to them. We only do if they're going to do a crime like kill themselves or somebody else. We view, and as a consequence, we view hospitalization as a punishment rather than a respite because it's going to be a 3 or 5 day affair. Load them up with medications, even though our medications take weeks to work, and kick them back out without adequate follow-up. I mean, that's what care has become. And it is a punishment to get care rather than something that people would embrace. And other countries have this better, where they can get care. They don't end up being bankrupted by care. It can be in the community, and they're not shamed quite as badly as here. And I think we can do that here.
Excellent. And I am again, Nick, I am looking at the Q&A and comments. I don't see anything emerging, but we do have a few more minutes. You know, I uh, as I told you earlier, I really appreciate not only um, all the experience that you have over the decades and that your teaching and your clinical work, and the ways then too that you have thought about what needs to be corrected, how much of this is a part of the corporate care model, how much it is, in some sense, a lack of our social compact with each other. Like this should not be acceptable. We should not be allowing this to happen. And so I see you have given us a renewed sense to really investigate the single payer option, to think about our own investment portfolios, to sort of see where we may be contributing. Um, I think it's been quite a mind-opening experience to hear you speak about your book. What other things would you like to leave us with?
Well, I mean, one statistic I didn't bring up with that when we base things on the financial model, for example, wealth, like wealth, the distribution of healthcare becomes uneven when it's on a financial model. African Americans access mental health care one half as frequently as whites. And as a consequence, they are now 40% of the homeless and over half the prison population. And with the poor reimbursement of mental health, and you pay for this extra school with therapists and psychologists, 88% of psychologists and 95% of MFTs, Master's Level Therapists, are white. 1% of Master's Level Therapists are African American. I mean, we have this separation in our society by finance about who will get care. So the poor get sicker and the sick get poorer. This is not a model that works.
Yeah,
We need, and I think that's why we need single payer. Nobody wants to pay for this, but we need to do it as a community, as one. Nobody wants to go tell the person who's ranting on the street to shut up or calm down. We need to do it as a society. And I think this is a symptom and a cause of our societal community breakdown. We just need to do this together. And I think single payer is the way to do it. So it's not more for me means less for you. It's where all of us getting healthy makes all of us better.
thank you. Two other comments that came in as you were speaking. Norma mentioned that in her family, injections of Risperdal, is that right?
Risperdal,
Risperdal.
yeah.
Yeah, it is working very well for you to know that.
Oh, well, thank you. Well, these medications do work. They're not cures. And, just handing somebody a pill or a shot is just one small step. They're going to need probably lifelong care, but getting them a job, a situation where they can have friends, where they can feel proud, they don't have to hide, and the family doesn't have to hide them. People can, we, People with disabilities can add to a community and don't have to be an embarrassment. We all feel better when somebody is working and contributing. Why can't we do that?
Yeah, so important of a point. And Carolyn Clark in the chat has put in a link to other resources, some local resources. So she said flawed, but still a starting place.
Oh, absolutely. We
Yeah.
need to support these. One bit of problem is that I hate that these have to be these fringe kind of
Mm,
like standalone nonprofit or underfunded things. It just needs to be part of healthcare. I mean, more power, and thank you for putting that in. We have to support
mhm.
these things, but we need a fundamental reboot on how we handle healthcare and mental health care.
Nick, thank you so very much for today.
Well, thank
Um,
you all so much for attending, and you can access me certainly online if you want, and I'd send you to the book, and but certainly contact me if you have other questions.
and I think, yes, your book should be shared with others. My brother's keeper, Nick, we are in your debt for your work. Thank you very much for today.
Oh,
And
thank you so much.
yeah, good weekend to everyone who's joined us today. Thank you.